now that we've talked about the younger patient and how we look at the younger patient, although it's a similar algorithm, I believe, but how, Dr. Daver, how would you approach the older patient? And I know older is a
Right.
loaded
It's tricky.
term, so I'll let you define that. But older,
Yeah.
how would you approach the older patient that comes into your office with AML?
Yeah, I mean, I would say today in a we see many of these a week, right? So I think above 65, we're taking a very close look at, do I really feel that there's a clear benefit of intensive chemo? And I think there, as I was mentioning, probably the NPM1 without other additional high-risk mutations or the core binding factor, we would consider intensive chemo with curative intent. But that's about 15, 20%. For the rest, I think we are in general leaning towards lower intensity therapy. So then we do look for the mutation. So if they have a FLT3, then today on trial, we have HMA-VEN with a FLT3 inhibitor, either GARRET or Quiz. Even off trial, if I have a 69, 70-year-old and they look robust, I would probably go for such an approach and maybe then consider transplant, depending on their molecular clearance or tolerability. Same for IDH1 and 2. If they have it, then we're considering HMA-VEN. Potentially, if we have a trial with the addition of an IDH inhibitor, and now with the menin inhibitors moving to the front line, it would be HMA-VEN. Consider adding a menin inhibitor in those who have a NPM1 KMT2A. And then for the rest, it's really kind of a low-intensity VEN backbone. HMA-VEN has kind of been the regimen we've used. We also have like a cladribine low-dose VEN, which has shown some good activity in that 65 to 75, so a little younger than the VLAA, but not really giving intensive chemo. So I think very little intensive chemo, more building on HMA-VEN, although realizing that HMA-VEN doublet, still gives you only about a 25% long-term survival. So we still need to do more. And so that's where some of the high-risk groups, the FLT3, the MLL, we're starting to add a third drug and starting to see early promising data. Yeah.
Dr. Abaza, what do you think?
I completely agree with Dr. Daver. That's what we also do. I think one thing just to add, or that we factor in, is are they transplant eligible? Do we have a donor? Because I feel that if they don't, it's going to, if I do an HMA-VEN approach, I'm sort of, and if they're fit in a sense to intensive chemo, they're sort of on this long term, and it's not something we can stop. Where if we do an intensive chemotherapy approach, at one point I can switch to an onureg or oral azacitidine maintenance strategy, which then sort of frees the patient from being committed to HMA-VEN based approach, which is not the easiest for patients, especially with the burden of the treatment and the infusions. So that's the only thing we also factor in. If I know that they are transplant eligible and the likelihood of having a donor is pretty high, then yeah, doing a triplet regimen like aza-ven gilteritinib, like we have on trials, or something similar, and that's what I think the group at MD Anderson just published, that there may be a role for these triplet and older fit patients to bridge to transplant, sparing the intensive chemotherapy-based approach. So that may get us to the same, finish line with less toxicity from the intensive chemo.
And I think you both are absolutely right. We are seeing a trend more towards the HMA-VEN movement towards patients over the age of 65 and even some patients over the age of 60 who are otherwise fit for transplant. And I think one of the things that will be very interesting on the upcoming years is some of these trials that are out right now comparing induction versus HMA-VEN, such as the MyeloMatch trial or such as the industry-sponsored trial that's looking at this as well, because that will really provide us with a very good, clear answer in terms of, we all feel comfortable inducing somebody who's under 60. We don't feel, not to say we don't feel comfortable, but we're giving second thoughts because it may not be as important as it was when we didn't have something like HMA-VEN. I think it's a big step forward in terms of how we can mitigate toxicity for our patients.